Good morning, this is Dr. Joe Moscato on one of our series of lectures, and this is on myeloproliferative diseases, something that's pretty confusing to a lot of people, especially when you see them as inpatients because they have long courses before you see them. Now, myeloproliferative diseases, or MPD, include multiple diseases. The common ones are polycythemia vera, essential thrombocythemia, primary myelofibrosis, and actually in this category is chronic myelogenous leukemia, but usually we separate that into a different category. So usually the first three are the ones we're really... Now, a complicated and commonly confused issue is the difference between myeloproliferative diseases and MDS, or myelodysplastic syndrome. MPD is characterized by an increased bone marrow proliferation of myeloid cells or any or all of red cell, granulocyte, and platelet precursors. There's no evidence of dysplasia and usually manifested by increased cell counts. MDS, on the other hand, is characterized by abnormal and dysplastic maturation in the bone marrow and often pancytopenia. So the people that you transfuse in OPMO are almost always the MDS patients and almost never the MPD patients unless it's end-stage disease. Now, P Vera is characterized by an increased red cell mass, plethora, the symptom of post-bath pruritus, splenomegaly in some of the patients, oftentimes an elevated white count and platelet count, and control of hemoglobin is essential, and thrombosis is a common complication. The classic diagnosis is made by an elevated red cell mass without secondary causes such as hypoxia, hereditary, hemoglobin disorders, tumor, or renal disease. Splenomegaly can be in the diagnosis, and a clonal abnormality other than Philadelphia 1 or the BCR-ABL characteristic of CML. Now, secondary criteria for P Vera are platelet counts greater than 400,000, elevated white counts, bone marrow biopsy with pan-myelosis, and a low EPO level. However, this is all changed because now with the use of a JAK2 we can make a diagnosis much more clearly. So the major criteria now are elevated red cell masses, a hemoglobin of greater than 18.5 in men or 16.5 in women, and if a JAK2 is mutated it's almost pathognomonic of P Vera. The minor criteria is your note, and one needs two major or one major and one minor criteria. But since the JAK2 is mutated in 95% of patients with P Vera, it's a fairly good test. Now, proposed criteria for essential thrombocythemia are sustained platelet counts of greater than 450,000 and a bone marrow biopsy consistent with megakaryocytic hyperplasia with some increase in large mature megakaryocytes and not meeting the candidates for others. JAK2 is mutated in about half of the patients. Primary myelofibrosis proposed criteria are megakaryocyte proliferation and atypical plus reticulin fibrosis, not meeting other criteria. JAK2 may be mutated or not. And you see the minor criteria of leukoerythroblastosis, increased LDH, anemia, splenomegaly. Now, this is an unusual diagnosis. Usually, myelofibrosis comes from end stage of the other diseases such as P Vera and ET, rather than primary, and of course it can be difficult to determine. Interestingly, in one of the new drugs that is just coming on the market, Nplate, or a thrombopoietin mimic, the toxicity is reticulin fibrosis, which is kind of interesting. The treatment of P Vera, or with an elevated right count, is quite straightforward. Phlebotomy is the mainstay of therapy, and the goal, interestingly, is iron deficiency. So one is trying to make these patients iron deficient. One of the confusing things, I think, for a lot of people is the difference between hemochromatosis and P Vera. In P Vera, this is a disease where you make too many red cells, and you need to get the red cells down. With a hemochromatosis, the problem is iron. The patients absorb more iron. They don't make too many red cells, they just have too much iron, and one needs to phlebotomize to get to iron deficiency in those patients. These patients, when they become iron deficient, remain with a normal hemoglobin. If not successful, hydroxyurea is used. Low-dose aspirin is often accompanies this to keep thrombosis down. And other treatments can be used for failure, such as anagrelide, interferon, P32, and for itching, antihistamines, and SSRIs. The course of P Vera is generally slow progression. Many patients live 10 to 20 years. Eventually, the course is complicated by myelofibrosis and splenomegaly, and ironically, at that point, they may need transfusions, which is when you usually start seeing them in the hospital. There's some transformation to AML, and it's more common if the patients have been treated with P32 or chlorambucil, neither of which we use very much anymore. ET treatment is a little more difficult since we can't really remove platelets for any sustained period of time, although occasionally platelet pheresis is used. For initial platelet counts of greater than 1 million or any thrombosis or bleeding, we will try to lower the platelet count immediately, either using large doses of hydroxyurea or platelet pheresis. Very high platelet counts can lead to artifactual hyperkalemia, and you have to be watch out. Somebody comes in with 1.5 million platelets, and they'll break up in the test tube, and your potassium may be 7, but it isn't really 7, it's an artifact. Further treatment with hydroxyurea and low-dose aspirin or anagrelide can be used. The clinical course is measured in decades. Eventually, myelofibrosis and pancytopenia intervenes, and again, occasional transformation to AML, but less often than in P Vera. AMM is just simply the presentation with myelofibrosis. There are high risk factors of lower high white counts, low hemoglobins, and the median survival of no risk factors is 7 years, and both risk factors about a year. And symptomatic splenomegaly and bone marrow failure are common, and what's called extramedullary hematopoiesis, so a lot of the marrow is actually functioning in spleen and liver and even in lung, which can be a problem. The treatment is transfusions, control of painful spleen, occasionally hydroxyurea thalidomide. Splenectomy has significant mortality both for primary and secondary myelofibrosis, usually from bleeding or thrombosis, and can lead to extramedullary hematopoiesis in lung and liver, so it's a really significant problem. In young patients, allostem cell transplant is used. When you see MPD patients in the hospital, usually managed for years in the office before you ever see them, they're often hospitalized for initial problems such as a very high platelet count, and then later for thrombosis and bleeding, surgical complications, and transfusion. So you're seen in sometimes the end stage of the disease or the very beginning. There is hope for the future. The discovery of the JAK mutation is really exciting, especially for P Vera, since now there are already drugs in the works being developed to block the JAK2 mutation protein, and we hope that that will help treat the disease. We're not sure if this will be similarly true for ET and PMF, but there's great hope for the future. And still the life expectancy of these patients is long, and these patients often feel fine with good management for many years. So as usual, I hope you learned something from this, and if you have any questions, don't hesitate to let us know. Stop us and ask us. Thank you very much.